Good evening. This is Dr. Bernstein with your October 2017 teleseminar. Before we begin, let me warn you about my answers. I'm answering questions for the benefit of the audience, not for the benefit of the individual questioner. I cannot get a complete physical examination or history on individuals who submit questions, so my answers are purely guesses, and the guesses are made to be informative for the general population and may not be the proper ones for the individual. The first question: can you please offer any advice? I am moderately obese with a fatty liver and am at high risk for heart disease. I am a 66-year-old female. Well, I'd advise this person, first of all, if she's diabetic, to read my book, Diabetes Solution. And if she's not diabetic, to read Diabetes Diet, because that diet is really for anybody. Originally, I had called it the diabesity diet. That was long before anyone else had used that term, and the publisher refused to use that expression. So read the diabetes diet at the very least. It helps you to lose weight, and if you're diabetic, you certainly have to normalize blood sugars if you have a fatty liver. And as the readers of my book may know, I had a fatty liver when I was 13 years old due to high blood sugars, and I had it most of my life until I was about 35 when I finally normalized my blood sugars. I have ordered some 100% sucralose with none of the added sugars that the stuff on the store shelves has in it. Do you know if it elevates blood sugars? I've not, I've actually had the sucralose tablets, and the sucralose tablets did not elevate my blood sugars, and according to the literature, they're not supposed to. Now, if this person has had sucralose powder, there is the hazard that it might be mixed with other sugars. Certainly, if it's in the packets, there's a high likelihood. And as I warn in my book, powdered sweeteners in packets or powdered sweeteners in general, other than stevia, usually have added sugars as a bulking agent. I've had type 2 diabetes, high C-reactive protein, and have been on a ketogenic diet for 3 months, losing 28 pounds. I've been experiencing tightness of my hips and have little lateral movement for several years now. Doctors put me on medication, sent me to a chiropractor and physical therapist. Nothing helps. Will this eventually get better by eating a ketogenic diet? Well, this person says they have type 2 diabetes. My guess is that they have a diabetic complication called amyotrophy. I might add, by the way, also called amyotrophy. And of the 3 physicians in the USA who can properly pronounce this word, I think I'm one of them. That's my claim to fame. Amyotrophy is a weakness of the hips and knees, in particular, difficulty abducting the hips, where if you're standing and try to lift your leg, let's say your right leg to the right side up in the air, or your left leg to the left side, that's abduction, that's impaired in these individuals. And I have had patients with amyotrophy, and I've seen it get better over a period of years after they've had really normal blood sugars. It has nothing to do with the ketogenic diet. In fact, one hazard of most ketogenic diets is that they underfeed protein. And if you're underfeeding protein, you're likely to have muscle weakness independently of everything else. So read my book, Diabetes Solution, eat enough protein, and keep your blood sugars absolutely normal. Do I have a problem if my A1C readings are in the high 3s rather than 4s? Well, it looks to me like the 4s would be in the 70s and 80s, and the 3s would be in the 60s, but it all depends where you get the A1Cs done. For example, there's a commercial A1C system for you to do at home that's grossly inaccurate. And I certainly wouldn't use that as a gold standard for my A1Cs. If you go to a clinical laboratory and your A1Cs are in the 3s and 4s, you'll be the first person I've met to be in the 3s. I have a number of patients in the 4s, but I would say that there's a question in my mind as to how a person manages to get so low, and I would think that what you should be looking at is your blood sugars, not your A1Cs. There are certain conditions that, hematologic conditions, that will give low A1Cs, and different labs do have different normal ranges. But I would look at the blood sugars, not the A1Cs. Read my book, Diabetes Solution, to see what your blood sugar should be. My doctors have been so useless and have made me a lot worse with their outdated and inflexible methods. But I am a young woman, 24 years old, and have been type 1 diabetic for 13 years. My feet are going numb after 6 years of pain, and my hemoglobin A1C ranges from 7.4 to 8.2. My doctor says it is dangerous to lower it below 7.5. Well, this is a typical statement. I get tempted to answer this every month practically because it's such a sad thing. It's almost universal, it seems to me, that endocrinologists advocate high blood sugars. And I'll repeat again the arguments that I've been given by some top people in the American Diabetes Association years ago that are still given to me by endocrinologists. Goes like this. Let's say I'm an endocrinologist. I have 3,000 patients. They're all diabetic. If they go blind, if they have their legs amputated, if they have terrible burning pain in their feet, if they develop end-stage kidney disease or die of congestive heart failure, these are all natural consequences of the disease. But if one person dies of hypoglycemia, I get sued. So I'm not going to allow any of my patients to be remotely near normal because that's too close to hypoglycemia. And I might now add that endocrinologists, for the most part, don't know how to treat diabetes, how to prevent hypoglycemia if your blood sugars are in the normal range, because they have no experience and they've never been taught how to achieve normal blood sugars in their patients. So this person should certainly read my book, and it might take years for the numbness to go away and the sensation to return in her feet. And there's one other warning, which I give in the book, that when the nerves resprout, there could be what's called lancinating pain. It could be extremely painful while the nerves are regrowing, and this may take several months, but usually people can tolerate it because they know that the nerves are recovering. Why do the menus calculate meat in ounces rather than grams? Well, you could ask it another way. Why do you buy meat in ounces rather than grams? That's the way meat is sold. So it makes sense for menus to dole out meat the way it is sold. That's how simple it is. In your book, you say most people do not need more than 7 units of basal insulin per dose. Is 13 units of morning Levemir and 9 at bedtime too much? Well, I don't say that in my book. It's interesting how my books are repeatedly misquoted. What I say is that some studies have shown that the larger the dose of insulin that you inject into one site, the less predictable is the absorption of the insulin. And I mentioned that it's my absorption, my observation that for a small person like me, when I inject more than 7 units in a site, the absorption is less predictable. Now, if you have a big fat belly and want to inject 15 units, it might not be a problem. So it really depends upon the individual. 19-year-old daughter, A1C 4.6, diagnosed 2 years ago with type 1 diabetes, still on honeymoon by following your low-carb diet. No bolus dosing, only 3 units of Tresiba per day. Was told by a new endocrinologist that she could die in her sleep because she's not eating enough carbs to produce glycogen stores in the liver. How many extra carbs are necessary to produce life-saving glycogen that endocrinologist says is not provided by fat? Well, it's not provided by fat, but if she's getting adequate protein in her diet to maintain her muscles and grow, any excess of protein above that will be slowly converted to glucose and stored as glycogen. It can also be converted to fat and stored as fat too. But the endocrinologist told your daughter what they usually tell people. That's incorrect. Usually they claim that you need a certain amount of carbs for the brain for kids to grow, and that's a myth. In fact, what has been repeatedly shown is that when diabetic children have high blood sugars, they go off their growth curve. They drop from their growth curve. And when their blood sugars are normalized, they return to the growth curve. So, more misinformation. I want to try your low-carb diet against the advice of my doctors and dietitian, but I want to do it safely because it goes against medical advice the National Health Service gives. My doctors have said if I do it, they will not be able to advise me when my blood sugars are poor. How can I still exercise safely with low carb? Well, first of all, you have to read my book, Diabetes Solution. It talks about exercise and so on. Also, I warn you not to gradually increase the dietary carbo, but rather decrease, but to rather suddenly change everything, change your carbo and your insulin or whatever your other medications are at the same time. Now, if you are writing from the United Kingdom and happen to be in London, I have a patient who goes to St. Thomas's Hospital, where he has the lowest hemoglobin A1C that any of their staff have seen in diabetics. And they are so impressed that his physician there goes along with whatever he requests. So I can't tell you his last name, but if you go to St. Thomas's Hospital and say you want the physician who treats Simon with the low A1Cs, and if you're very lucky, you'll get a physician who will cooperate with you. This is a universal problem. It's not just in the USA, it's also in the United Kingdom, it's in Canada. It's especially difficult in Australia. Basically, the universe of physicians, especially endocrinologists, I should say endocrinologists, believe that diabetics are not entitled to the same blood sugars as non-diabetics. I practice scuba diving in summer. What can I do to keep my blood sugar under control while diving? As you can imagine, I can't carry sugar cubes with me. Well, first of all, you can carry the bottles of liquid glucose. You can even pack your own. You can put this in some sort of device that's strapped to you. Of course, you can't drink it when you're underwater, but you can surface and check your blood sugar and correct it with glucose. Now, one can say, how can I correct my blood sugar if I'm in the middle of the ocean? Well, usually when people are scuba diving, they have a boat nearby, and you can come up to the boat. You could have someone lean over and hand you your equipment, and you could check your blood sugar. And it may be inconvenient, but it's pretty dangerous to be scuba diving and not knowing your blood sugars. My son is 25 years old and has been diabetic for 11 years. His doctor told us to eat what you want, but take your insulin dosage to cover as needed. His A1C is now so high it won't even register, and he's already having neuropathy. A new doctor says that within a year he will be on dialysis if we don't get it under control. But when asked how to do all this, all they say is eat better. Well, this is a classic case for reading my book, Diabetes Solution. Now, it's unfortunate that this month, more than half of the questions are clearly from people who have not read my book, Diabetes Solution. And I've intended these seminars to be for people who have read it and have questions that the book doesn't answer. As it turns out, it looks like the book answers all the questions. I have diabetes type 1 for over 50 years. Well, this person is a survivor. On Lantus and Novolog, which are two insulins that I don't recommend. To treat high blood sugars, I have tried weight reduction, stress control, some exercise, and a few blood pressure meds. I am reading your book and starting the diet. What situations would exist for me to continue to take a beta blocker long term? I already have taken it for about a year. Well, first of all, if it's not causing any problems like depression, I'm trying to think what else. They used to say that it killed the signs of hypoglycemia, but and that's partially true. Epinephrine, which is produced when you get hypoglycemia, causes certain symptoms that let you know you're low, and the beta blockers will reduce those symptoms. Certain beta blockers, like atenolol, have been found in the scientific literature to raise blood sugar. It's unclear as to how much. If you have gastroparesis, I'm trying to think whether a beta blocker would cause, I don't think it would cause any problems. No. It might even make stomach emptying better. So it could be helpful for gastroparesis. In any event, I would suggest that you read my book, Diabetes Solution. Now we have the same question, except this person read an article published in July 2017 that says that beta blockers had that diabetics on beta blockers had increased risk for cardiovascular events. Well, I read the same article, and in particular, there was only one beta blocker that was tested, and that was atenolol. So we don't know whether it's beta blockers in general or just the atenolol. How much Lantus does a prepubertal child of 11 need? She is at her peak rate of growth and taking 18 units in the morning and 18 at dinner. According to what you have written, it sounds like she should be taking lower doses and her evening dose should be moved to bedtime. She's taking a lot of basal bolus insulin, is constantly eating, and is now overweight. Well, I have a feeling that my book is not being followed. You really ought to read it very carefully. I'm trying to think. First of all, I would not use Lantus insulin for a variety of reasons. If you've listened to these seminars, you know that there's the hazard of increased risk of cancer, and it's not a truly flat insulin, so Tresiba twice a day on a rising and at bedtime would probably be more important, more effective. And for some people, they even have to take the morning Tresiba very early. For growing children who frequently need extra insulin, and I doubt that this child, unless she's grossly obese, would need 18 units of basal twice a day. But growing children do tend to need more insulin while they're in a growth spurt. And what I do is I give them metformin, not the generic, but the brand Glucophage, usually the Glucophage XR, which is the timed release. I usually give it twice a day, morning and bedtime, and it seems to stabilize the insulin requirements, making them less exaggerated and less uncertain during growth spurts. So that could be helpful. So I would say at least two things. Read my book, follow it carefully, but also get your doctor to prescribe Glucophage XR. Now, for a small person, I would say, or 11-year-old, probably 500 milligrams twice a day would be reasonable. you have to watch out for diarrhea, which usually is preventable if you use it properly, and that's all covered in the book. But it's covered when we talk about type 2 diabetes in the book. Type 2 for 13 years, good control thanks to your words and books, but found atrial fibrillation early May and am now on warfarin, that's an anticoagulant. Any comments on watching to keep good A1C or any other side effects to watch for? Well, I haven't seen any adverse effects of warfarin upon the hemoglobin A1C. This fellow says, or it could be a lady, his A1C goes from 5.2 to 5.4, which is an average blood sugar of 108 to 116. So he could try to get his blood sugars a little bit lower. Let's see what the next question says. I would like to know if the action profile of NovoRapid subcutaneous and regular insulin intramuscular are very different. I have an 11-year-old daughter and have tried both. Don't find much difference, so I'm wondering if I should just stock both the long-acting and regular insulin and forget about the NovoRapid. Also, dosing of NovoRapid is difficult for us as we can't get diluent here and syringes with half-unit increments. Well, this parent read my mind because that's the problem with Novolog, NovoRapid, which in the USA we call Novolog, which is 50% more potent than regular, and therefore very hard to read on a syringe in small doses. And here this father cannot get syringes with half-unit markings, makes it even more difficult. And he can't get diluting fluid, but what I'd suggest you do is what I do. I only use regular insulin intramuscularly for corrections, and when I get time to breathe, I'm going to dilute my regular to make it easier to measure, because 1 unit of regular will lower me by 60 milligrams per deciliter. Now, in your particular case, you can order syringes with half-unit markings from outside your from outside your country. You could go to Amazon.com, or you could go to pharmacies that have the syringes with half-unit markings. As far as the diluting fluid goes, a recent study shows that you can use normal saline, sterile saline, 0.9%, and it's available from pharmacies all over the world. You can usually purchase it in bottles of 50 cc's, 50 milliliters, and use it to dilute your insulin. Now, if you can also get empty insulin vials from the manufacturer, or if in your country you cannot get it from the manufacturer, you go on the internet and you could get empty insulin vials from a variety of sources. They're very inexpensive, and you can even reuse them possibly. The empty vials would be for the purpose of making the diluted insulin. You put some insulin in the vial and you put some diluent in the vial until you get the right concentration. Our 7-year-old daughter has been experiencing lows in the morning and then highs above 200 in the afternoon. We are following a low carbohydrate, high protein diet less than 30 carbs per day. Well, right off the bat, for a 7-year-old kid, it should be a lot less than 30 grams of carb per day. Depends on her weight. If her weight is 50 pounds, I'd say, or it should be 15 grams of carbs per day. I advocate that the carbs be adjusted to body weight. My recommendation in my book of 30 grams of carbs a day is based upon a 140-pound person. We are wondering if we need to give her more calories. She has about 150 for breakfast, 400 for lunch, and 500 for dinner. She is currently on 9 units of Lantus given at night, Humalog for carbs, and R for protein. Is she getting enough calories for her age? I usually don't work with calories. I work with what it takes to get blood sugars normal, and then we look at body weight and rate of growth. I would suggest that you read my book, Diabetes Solution, and we give whatever it takes to maintain, to get target body weight. Now, your pediatrician will know what her body weight should be. He probably has a growth curve. She probably, upon becoming diabetic, fell off her growth curve. He would know where she should be in weight and in height to get back on the growth curve. And you keep adding protein until you get the right weight and height. You don't look at total calories. You look at weight and height. Now, use the book. She'll probably do better with Tresiba insulin twice a day. Humalog is a catastrophe. Most patients who use Humalog don't get normal blood sugars because it's too concentrated, too hard to measure. And you should even be diluting the regular insulin. One other thing you could do is visit Type 1 ONE Grit, Type 1 Grit on the internet, and see what other people are doing with type 1 diabetes. I find that Tresiba is too flat and I need a higher amount of basal during the day. Do you have any patients using a small percentage of NPH to adjust basal with Tresiba? Well, first of all, if it's flat, that's what we want. We want our basal insulin to be steady state. The one problem that I've observed with Tresiba is going up in the morning. It's as if the bedtime dose is not adequate for handling the dawn phenomenon. The dawn phenomenon can, for many people, be almost like eating a meal. So I have some patients who are taking Tresiba who, on arising, have to take a rapid-acting insulin. Some of them take regular insulin on arising. Some of them take Humalog, especially obese ones, and some even take diluted Humalog to work fast to fight the dawn phenomenon. I've never had complaints that it was too flat, although one can imply that from what I just said. I've never seen anyone add injections of NPH to the injections of Tresiba. It sounds like something that might work. The one trouble with NPH is you have to shake the bottle every time you use it, which, number one, is sort of a nuisance, but number two, people forget it frequently, and then you don't get the same dose. You might want to take a close look at my book, Diabetes Solution. There may be some tips, not specifically about Tresiba, but about blood sugars throughout the day. And also visit type 1 grit, like I mentioned before. I am new to your protocol and have been a type 1 diabetic for 26 years, another survivor. How is it that you have gotten your insulin requirements so low that you have to dilute your regular down? Well, it's not that I've gotten my insulin so low. Well, one could say that if you don't eat high carbohydrate foods, and I would suggest this person read my book, I weigh about 112 pounds. I don't need a lot of insulin. If I weighed double my weight, I'd need at least double the insulin. Why do I say at least? Because if I had a big belly, if I were the same height and had double the weight, I'd be insulin resistant, and I'd need more than double the amount of insulin. Does your insulin sensitivity improve over time on the diet? Well, it's not a matter of insulin sensitivity. If you are on a low carbohydrate diet, you don't need huge amounts of basal insulin to cover the carbohydrate. Were you able to reactivate your beta cells? My beta cells, I thought, were long dead by the time I discovered blood sugar self-monitoring and worked out a way for normalizing my blood sugars. But I then encountered a new phenomenon, and I might add that other patients of mine have encountered the same phenomenon, and these are people with common variable immune deficiency who are receiving intravenous or even subcutaneous gamma globulin. Their beta cells seem to partially recover. Now, mine, I've experienced that, and it's strange that my recovery is at dinner time. My blood sugar starts dropping before, if I sit down at the table or if I don't eat dinner, without injecting any insulin, my blood sugar drops at dinner time. It's a strange phenomenon. It's not that helpful, but other patients of mine have the same effect of insulin appearing out of the blue inappropriately. Do you recommend fasting from 8 p.m. until 2 p.m. next day for type 1 diabetics and exercising before eating? This is strange. I'm worried about my 36-year-old son who said he is following your book. He tells me his paleo diet is fine for him, but he is always short-tempered. Basically eats 2 times a day. He goes to bed around 12 to 2 and does not eat for at least 14 to 16. Is that safe? I suspect that he's not following my book. I also, if he's always short-tempered, when you're with him and he's short-tempered, ask him to check his blood sugar. It may be that he has a low blood sugar much of the time. So I'd say that he probably, and when he calls his diet a paleo diet, we really don't know what he's talking about. Most of the paleo diets that I've seen advertised on the internet or I've read about in books are inappropriate for diabetics. They frequently have a deficit of protein and are advocating fruit. So I don't know what he's up to. The important thing is to check his blood sugar when he's ill-tempered and try to get him to really read my book. Child with congenital hyperinsulinism was cured at age 9. Is he at increased risk of diabetes And how would you treat him? Well, I have no idea what his history is, whether he had a pancreatic tumor that was producing insulin. So I really can't, if he merely had reactive hypoglycemia, which I've seen in a lot of people, that particular condition is a precursor for type 2 diabetes. And you treat these people with high protein, low carbohydrate diets, and many of them will need frequent protein snacks during the course of the day. What this particular child has, I don't know. Why do type 1 diabetics have trouble with declining blood sugar during exercise when non-diabetics do not? Surely maintenance of blood glucose during exercise is regulated by alpha cells and not beta cells. Well, that's not quite true. And non-diabetics do have trouble with extreme exercise. Those of us who are old enough will remember how marathon runners would run into the wall after about 20 miles because they used up all the stored glycogen in their body. It's not an exclusive problem with diabetics. Now, diabetics can go up during exercise if they don't have enough insulin on board. Now, exercise does something that insulin does. It mobilizes GLUT4 glucose transporters. You could read about these on Wikipedia, GLUT4, the Roman numeral, no, I'm sorry, the Arabic numeral 4. Insulin mobilizes glucose transporters from inside the cell to the surface, where they drag glucose into the cells to keep it alive and metabolizing. Exercise also brings glucose transporters to the surface, just like insulin does. So exercise can lower blood sugar. And it can do this in both diabetics and in non-diabetics. How do I establish the optimal basal insulin? I suffer headaches quite a bit, even with good blood sugars, and am nearly debilitated. I'm thinking I could be over-insulinized. Well, again, I'd recommend that you read my book, Diabetes Solution, but also, if you get a lot of headaches, you might visit a headache specialist. Most university hospitals have at least one headache specialist who usually is a physician who gets headaches himself, and usually a neurologist. And he went into this profession because of his headache problems, and they're usually very sympathetic to people who have headaches and can diagnose why you're getting headaches. Now, it's true that low blood sugars can cause headaches, and if you only get headaches when your blood sugars are low, then read my book and see what you can do to keep them normal. Speaking of reading my book, next question, we have read your book. Since starting school, my 14-year-old's son's glucose levels spike in the 170s to 180s. He has expressed to be under stress. The Dexcom reading goes up to 120s the moment I drop him at school. Glucose goes as high as 200s before lunch and before the regular insulin he receives for breakfast wears off. Can stress cause such high levels of glucose in and of itself? Well, yes, it can. What's the best way to address this? Well, there are lots of ways, I think. You could take them to a psychiatrist, but I find that I have a number of kids, especially the athletic ones and the ones who are really good athletes who perform on school teams. When they have a real match, not just practice, with a competing team, their blood sugars go up. And what I've found is very helpful is to give them a beta blocker. I usually use propranolol because it's rapid acting. So we give rapid acting propranolol, a small dose, maybe an hour before the anxiety sets in, and it prevents the blood sugar rise. It also reduces the symptoms of anxiety. I've also tried this with performers and teachers, people who address audiences, where they get nervous before a performance, and we give them propranolol and their blood sugars go up. We give them propranolol and usually it doesn't help. The blood sugar doesn't go up. Counseling, increase in basal insulin, change basal insulin, long-acting, anxiolytic medication, or a combination. Well, you can try anxiolytic medication, but you might find that propranolol is the most benign of the things you try. I'm not trying to pitch propranolol. There are anxiolytic medications that may be helpful, but it happens that many of the anxiolytic medications are habituating and cause development of a tolerance where you have to take higher and higher doses. So there are potential problems. One other possibility with regard to the blood sugars would be to use glucophage XR, as I had suggested for kids having growth problems. Growth spurts. But that would be just experimental. I don't know whether it would work. It would be an experiment. Next question. For type 1 diabetic, do you recommend regular insulin over Humalog, and if so, why? Well, you've heard me recommend regular very strongly over Humalog because the Humalog has twice the potency of regular. So in my case, 1 unit of regular lowers me 60. 1 Humalog would lower me 120. And if you had a child that had half my weight, 1 unit of Humalog would lower her by 240. So the Humalog would have to be diluted, and you can painlessly inject regular insulin intramuscularly, as indicated in my book, and if you want really fast action. I understand from your book that I should be on insulin to preserve my pancreas function. This is not the opinion of my GP or specialist consultant, as my pancreas is still producing a little insulin and I am following your recommended diet. What is the smallest amount of extra long-acting insulin I could use? I weigh 64 kilograms. Also, I will be able to run without constantly checking my blood sugar. Will I be able to run without constantly checking my blood sugars? I'm terrified of hypos. Are there any diabetes consultants following your program in the United Kingdom? Very hard to find diabetes specialists anywhere in the world. I think I know of 3 people in the world who use my methods and are doing it effectively. One is not a physician, he's a PhD. Another is a naturopath, and the third is a physician in a distant country. I don't know of any in the USA. I have encountered some in the USA who used my book for treating type 1 diabetic physicians who used my book for treating themselves, but not for treating their patients because it takes too much of their time and they don't get paid adequately for their time. So it's a real problem. And what you could do is follow my book, use a more friendly GP who would believe in normal blood sugars, and avoid endocrinologists if possible. I mentioned before about the one doctor at St. Thomas's Hospital in London who treats a patient of mine and has been very cooperative. The long-acting insulin that would be appropriate would probably be Tresiba, and you could get doses, if you use the right syringe, as small as a half unit, maybe twice a day. You can actually purchase, if you can't get syringes with half unit markings, you could get them on the internet from another country. And I certainly advocate absolutely normal blood sugars to preserve your beta cells. And I've seen this occur over periods of 20 years, where I've treated people for 20 years and they're still producing insulin because we kept their blood sugars normal. Okay, let's see what we have here. This is a very long question, but I'll read it anyway. I was diagnosed with diabetes 9 months ago, 45 years old, with an A1C of 11.3, which I don't even know how high that is, but it's probably somewhere around an average blood sugar of 300 milligrams per deciliter. A BMI of 22, so this person is a little overweight, not very overweight. I switched to a very low carbohydrate diet, recently fine-tuning with your food lists, and have had an A1C of 6.1 and a BMI of 19 for the past 7 months. So 19 is pretty normal. My fasting C-peptide is below the normal range, and I have no phase 1 insulin response. I have continued to exercise 2 times 50-minute running intervals, first and last thing of the day, and 15-minute walks after eating and 2 hours after eating. I've had polycystic ovarian syndrome, so this is a lady, since I was 18, and am on metformin. My GP doesn't think I need insulin, but my 2-hour after eating blood sugars range from 8 to 11. So this is someone from the United Kingdom. That would be from 96 to, let's see, about 120. My specialist consultant thinks I am honeymoon period type 1 diabetic, but I'm still hoping I am type 2. I'm a thin type 2. Should I consider taking insulin? First of all, read my book. And you do whatever it takes to keep blood sugars normal to preserve beta cells. Now, an current A1C of 6.1 is an average blood sugar of about 144. So we know that elevated blood sugars are toxic to beta cells. You want to preserve them, so you do whatever it takes. You read my book and figure out what you have to do. You may need some insulin or you may not, I don't know. There are a number of oral agents that I recommend, in particular glucophage and Avandia, and that's about it. An endocrinologist was told that we fed an 11-year-old 15 grams of carbohydrates per day, and he called that extreme. The accusation isn't true, but I would like to know whether you believe that it's extreme to feed children this amount of carbohydrates. The child is at the 93rd percent for weight and is type 1. So this this kid is apparently overweight, and he may not be getting enough vegetables with a total of 15 grams of carbohydrate. 11-year-old who's probably on the fat side, based on this, may not be getting enough vegetables. I'm not sure. I'd wonder what his height is. But I'd suggest that they read my book and try to keep his blood sugars normal. It's possible that as his size, if he's especially tall, that the 6-12-12 carbohydrate diet that I recommend for adults might be appropriate. If he's short, the 15 grams per day, which would be 3, 6, and 6, might be appropriate. It's all trial and error. And really, it's not the amount of carbohydrate, it's getting a good smattering of vegetables, not fruits. Young adult man, age 30, and physically active, presenting impaired glucose tolerance with impaired fasting glucose with 100 to 108 blood glucose every morning, but normal range of glycated hemoglobin. Of course, the normal range, if you go by the American Diabetes Association, is very high. When started running low carb, 40 to 60 grams a day, he saw getting morning blood glucose growing. 112 after first week, 116 after second week. Now ending third week, and intend to try a ketogenic approach, lowering carbohydrate. What do you suggest? Really strange case. Hope you could help. I don't know. I guess this is a doctor and talking about a patient. And I guess the 60 grams of carbohydrate per day is not doing the trick. And I don't like the term ketogenic because many of these people following the published ketogenic diets push fat, cut protein, and add fruits. So that the original paleo diet book did just that sort of thing. So I would recommend one that you have the patient read the book. You might want to try glucophage XR, and certainly cut way back on the carbohydrate from that 40 to 60 grams per day. And also, the patient might be overweight, so weight loss might be appropriate. Okay, let's see what's next. Well, I think we finished for tonight. Our next teleseminar is on Wednesday, November 29th. Look forward to seeing you then. Thanks a lot for listening. Have a good month.